Thank you very much. The recording is in progress, so that is good. My name is Peter Ventevogel, and I'm not Fahmi Hanna, who was supposed to chair this session. Fahmi Hanna is the co-chair of the IASC Reference Group for Mental Health and Psychosocial Support in Emergencies. We will hear in a minute from the other co-chair, Terry Umbalo, what that group is. She is joining us, but from Nairobi, where she lives. So she will give a brief presentation online. But Fahmi cannot be here due to a family emergency. And that was very unexpected. And he asked me to step in, and I hesitated. I thought, but I'm not IASC Reference Group co-chair. But then I thought, no, it's very appropriate. We all are the IASC Reference Group. So it's very appropriate that we do this. We are all part of this wonderful group, which I think is one of the, well, we should not be nasty, but a very good functioning, I would say, one of the best groups in the humanitarian system, a group of mainly technical people that have developed a close working relationship and close technical competency that is shared. So it's really a nice group to work, consisting of NGOs, UN agencies, but also governments. So you will see this also reflected in the panel. So in the panel, I have, let me go to the next slide already to show who is on the panel. Can you go to the next slide? Yes. So we will go to Teresa Umbalo in a minute. Then we will go to my colleague from the World Health Organization, Inka Weisbecker, who will tell us something on, I think, the minimum service package for MHPSS. Then Anne Filorizzo on my other side from Save the Children will speak. Then I will speak as a participant also in the panel. And Sophia from IFRC is then getting the floor. And IFRC is also part, even co-chair of this IASC reference group. So it's not only the UN club, it's also the Red Cross and Red Crescent movement. And then very happy to be joined with Marieke, who's working with the Ministry of Foreign Affairs of the Netherlands. So we also have participation of donors. They cannot vote, by the way, but they can sit and talk with us and fund us. Then we have Maria Brey next to me from Terre des Hommes in Lausanne. Oh, sorry, I forgot Guli. Guli, that was not personal. Guli and I are brothers for a long time, and we have fraternal rivalry. Guli from IOM, and I'm very happy to give him the floor because they do really marvelous work when it comes to community-based and other work on MHPSS. And then we have Ben Adams, who will join the podium at the end. And then we hopefully have time for discussion. Pardon?
And there's me.
Mais j'ai déjà fait ça, j'ai dit ça. Oh, sorry. And then we have Maria Brey from Terre des Hommes, Lausanne. I did say that, but then you interrupted me. Yeah, I'm not the kind of chair as Fahmi is, where everything goes smooth. Please bear with me. Now, what is the topic of today? And actually, I don't have to repeat that. We are in a grave situation as a humanitarian world. We are all worried about how things will go. And within that, MHPSS is vulnerable. We have built a lot of good things, good tools, good capacity, but we all feel that this is under threat. We are not going to have a negative talk today, but we're actually going to talk about what we can do also in the context of limited resources. So we will focus our talks on working in areas where the resources are limited and you can still do very meaningful work. That really is what we hope to show. With that, I think it's time to go to our first speaker, who is Terry Umbalo. Terry, are you with us? Now I should hear.
Yes, I am with you. I was trying to unmute, but I think the rights to unmute or mute are with someone else. Okay. I am glad I've been made able to speak right now. Good evening, colleagues. Good morning. I don't know where you're joining us from, but we are glad that you're here with us today to
Next
look
slide,
into
please.
this very important topic that we will be discussing. Next slide, please, Maya or Barbara. And indeed, I want to pick up on the last sentence that Peter has mentioned in terms of doing a lot more with very limited resources. I think in this field, we have been very innovative. We have been very lucky to be able to work within clusters and in clusters and to be able to respond in sometimes with very limited resources in ways that maybe people did not think that we could. For those who are hearing me for the first time, my name is Terry Ombalo. I'm the co-chair of the MHPSS Reference Group, together with my colleague, Fami, who unfortunately, like you've been told, is not here today, but I'm sure he's with us in spirit and we are with him in spirit too. Now, on to the next slide, please. In terms of what the reference group is, some of you are aware, but most of you may not be aware that following the 2005 humanitarian reform, the reference group for mental health uh, as much as maybe it may have been in existence before, but really came alive in 2007 to really start working in terms of delivering services to people who had been affected by various disasters. Following that reform in 2005, we've been able to come up with documents to guide the work that we do. And one of the documents that we keep falling back on, although it was done in 2007, is the MHPSS guidelines. This has become like the little Bible of the MHPSS or the little reference book of the MHPSS group. And a lot was done in that work. And following that, so many other documents and so many other guidelines have been produced, like you will be able to see in the next few slides. Emergencies have continued to happen world over. And as projected, there's on the slides, there is about in 2024, as recorded, 312 million people in need of humanitarian assistance. These may not be people who directly may need mental health and psychosocial support, but you must agree with me that in every disaster, there is always some form of distress that people go through that they will need support to overcome. Some are able to overcome the stresses by the very basic support that is provided within families, within communities, but then some are more severe and may require a more advanced mental health support. And so we are here to provide that to all the people who need it in all the emergencies worldwide. Now, in 2017, there were just 30 members of the reference group, while that number has doubled tremendously as we speak of 66 members in 2025. There could have been factors that may have made MHPSS slightly more famous in the last few years, but whatever it is, we are here to say that mental health is important and it should be provided to everybody who needs it. Now, the technical working group, or rather the reference group, now has technical working groups in 54 countries that are representing 59 MHPSS technical working groups. The number is slightly more because in some countries, you might have two technical working groups, for example, while in others, you only have the national technical working group. Now, in terms of the members, you also had Peter mention earlier that there are some members who can only speak, maybe not be able to vote or things like that. We have full members of the reference group, but then we also have what we call observers who also really help us in the work that we do. So far in 2025, up to 2025, we have 66 reference group members, full members, while we also have 23 observers who really support us in the work that we do to bring mental health to the people that need it in different countries. Now, the role of the reference group that myself and FAMI chair is really like fourfold, but there's so much that goes on between these 4 areas. And one of them is to support country level MHPSS coordination. Sometimes co-chairs in different countries reach out to us for advice or for technical guidance on certain things, telling us what the needs are, and then we are able to support them in terms of even development of materials, getting the things they need in their hands so that they're able to provide the support.
Terry, the time is up. You're on 4 minutes already.
Oh my goodness. Okay. We also provide and do such support with our colleagues who are at the table with Peter. And maybe they'll also be able to speak on what we do together and the resources I've already mentioned to be able to provide that while also being able to fit ourselves within the humanitarian structures. Next slide, please. Again, the number of technical working groups, I think this I've already mentioned in the overview that we have provided, and we can just go to the last slide because now the number really does present like 60% of countries. Is 68 or 60% of countries that need support that we're able to reach to? But I would really like to focus maybe a minute or my last minute remaining.
Yeah, you're over time, Terry. I'm very sorry, but you're over time. Can you do it very
Peter, for the advantage that I'm not there, maybe just to let you leave you with that slide on the materials that have been developed within the reference group that are out in countries that need support and to reach the people that need it. Thank you, Peter, and over to you.
Hi, Terry. We know each other for a long time. I get a red face because I am now
do the same to you, so it's okay.
stopping the co-chair of the group to speak. But we need to move on. I'm very sorry about that.
No
so thanks a lot, Terry. We may get back to you in the end because I would like to go to Inka Weisbecker now from the WHO, who will talk about the work that has been done on the minimum service package. So over to you.
Yes, thank you so much, Peter. And the MHPSS minimum service package is actually very relevant in these challenging times where we have to prioritize. And we can go to the next slide to talk about what is the MSP. MHPSS MSP is quite long, especially as an abbreviation, so we just say MSP. How many of you in the room have heard of the MSP? If you can raise your hands. Okay, how many have actually used it? Raise your hands. Okay, we hope the number of people who will use it will increase vastly after my 6 minutes are over. So it is a set of high priority activities for mental health and psychosocial support that are needed in every single humanitarian response. These activities are based on existing guidelines, available evidence, and various consultations and expert consensus that we've done over several years with actually much support and continued support of the Netherlands Ministry of Foreign Affairs, which we're very grateful for. The MSP is intersectoral, which means it's a common language between different sectors like health, protection, education, GBV, and it's designed to facilitate a faster, more effective, better coordinated response. Next slide, please. So what does it look like? The MSP is available as a PDF that you can download from the website, but we also have an MSP website where you can access the MSP and various associated resources. There's the address, and there you see a map of the world that shows you that actually over 210 countries and territories are accessing the MSP. So it's already very widely used in access, and I encourage all of you to go to the website and find your way around and explore it. Next slide, please. So here, this is a bit small to read, but I will let you know what it entails. So the MSP activities are divided in different sections. We have section 1, which is about MHPSS coordination, so across different actors and sectors, and assessments. Needs assessments are critical. We have to assess MHPSS needs in every emergency. So the section 1 is about coordination and assessment. Then we have section 2. This is about the activities that you always need, no matter what program you're implementing. Whether you're doing something in GBV or in health, you always need section 2. Section 2 are things such as monitoring and evaluation, ensuring staff competencies. So you will find something, or staff well-being as well. That is in Section 2. Now we have Section 3, and these are actually the programmatic activities. So there we have things like activities for children and youth, key messages about mental health integrated in primary health care, psychiatric hospitals, which are often not paid attention to in emergencies. So that is Section 3. And then 4 is specific settings such as infectious disease outbreaks or people in detention. Next slide, you will see that each activity is presented with a brief introduction. Why is this activity important in humanitarian settings? Next slide, a checklist of actions. Which actions need to be taken to implement the activity safely and effectively? And next slide, a list of relevant resources. This is also very important because we update the website regularly to make sure it always has up-to-date resources on how you can implement this activity best. Next slide, we have key considerations as well. These are topics that are sometimes slightly controversial or difficult, so they're included. On the next slide, you see that we also have a costing tool, which actually gives you an idea of how much do these activities cost in a specific setting. This is in Excel. You just need to input basic information like the country, affected population numbers, and you can do a lot with this costing tool, and we have a user guide for that. On the next slide, you see some associated tools. For example, we have an M&D indicator bank for the MSP activities. We have a workshop guide. If you want to actually do an MSP workshop for others, this gives you slides and instructions on how you can do that. We're currently also working on a multi-sectoral MHPSS assessment toolkit, which is out for field testing. We will finalize it this year. It's very important also for advocacy and for making sure MHPS is included in the response. We're looking for feedback at the moment on the toolkit as well. We have different sector guides. If you talk with GBV, with camp management, with shelter, this gives you guidance how you talk with different sectors about MHPSS or AORs. And lastly, I want to emphasize that MHPSS should be integrated as part of every humanitarian response across sectors. Whose responsibility is it to do MHPSS? All of us. And I think that's really the message of the MSP, and the MSP can be used for advocacy, it can be used for guidance, it can be used for collaboration, for decision making, and especially in these challenging times, we need continued commitment and resources for MHPSS, which is so critical to meet the needs of people affected by emergencies. Over. Thank you, Peter.
Thank you, Inka. This was great. And if you don't know the tool, check it out. It really is amazing and transforming the field. And I think we will talk more about it in the other sessions, as in the other contributions as well. So thank you very much. What I would also like to say is that I can imagine there are questions or remarks. We do encourage that. So for those online, there are 130 people online now, please do that in the chat. Write your name, your organization, and to whom you address the question or the remark. And for in the room, the same, but you have to keep it in your head while you say it. We now go to Anne Filorice, who doesn't have a PowerPoint presentation. She will speak right from her heart, and she works with Save the Children International.
And when you say from my heart, when I saw the topic today, I was facing kind of a Sophie's choice, like which country I'm going to prioritize, having to justify again why MHPSS has to be prioritized. So I took a step back and thinking, okay, in an emergency situation where resources are stretched to the limit, we focus to make tough decisions. What is essential? What can be cut? And the usual suspect will come up on the conversation: water, food, healthcare, shelter, basic needs. But MHPSS? Always questioned. So now we said interactive, but I'm not going to take the risk to launch a poll asking you whether MHPSS is life-saving or not. Instead, let me put the question to you in another way. By the end of this session, where all my colleagues and I have presented, let us know, will we convince you, have we convinced you that MHPSS is actually life-saving? So to start with it, I'm going to start with the argument against. It's simple. Crisis situation People need to survive first. They need food, they need clean water, they need medical care, they need a roof over their head. This is undeniable. If someone is bleeding, we're not going to offer therapy before stopping the blood loss. Obvious. And now let's take this logic a bit further. Let's think about an adolescent. She's pregnant, her partner disappeared, her parents doesn't want to support her, and she's giving birth to a baby girl, but she's by herself. And she's threatening, dealing with stigma, dealing with isolation, dealing with adverse event. What do you think is going to happen? Do you think she's going to be able to feed and care for her baby if no one is checking if she's okay? So this is not hypothetical. This is not just one case, one mother, one lady. No. This is many, many mothers. This is many, many caregivers. This is the community we're working with. Psychological distress, it just doesn't affect one individual. It ripples outward. It impacts the family, it impacts the community, and it impacts the recovery effort. So let's be clear, mental health crisis can be fatal. The stress, the traumatic situation, untreated mental health condition, they just don't cause suffering, they can lead to life-threatening situation. People in distress are more likely to engage into self-risk or risky behavior. Psychological distress impair the decision-making, making it harder to seek help, access services, or flee to danger when it's needed. In conflict zone, we know that people are forced to take a rapid decision. High-stake choices. Should I stay? Should I go? Where do I find food? How do I protect my family? If my cognitive or emotional resources are completely stretched to the breaking point, well, my decision can be catastrophic. It's been more than 10 years that we have gathered evidence proving that integrating MHPSS into emergency response improves outcomes. It reduces the long-term dependency on aid, foster resilience, speed up recovery. And somehow, we still have to justify it. Over the last week, as funding cuts hit the program in Iraq, in Yemen, in South Sudan, in Afghanistan, in Bangladesh, in Venezuela, in Haiti, and many other countries, my MHPSS team has been asked the same question. Why should we prioritize MHPSS? Again, isn't it like the extra services? Well, no. And we had to convince over and over again that in every program, we will need to ensure that our frontline worker will inform families and children in a child-friendly manner. This is where you can go if you need support from now. We don't leave you alone. We're going to work to find a place with you. Every mother who faces distress or mental health condition, we ensure that she'll find the support, because this is what's going to make the difference between a child undernourished who's going to die and the one who's going to survive. This is life-threatening. Every health sector, colleagues working on the sector, working on child protection, we urge them to listen to any adolescent coming with suicidal ideation and welcome them with support and no judgment. And that's life-saving, isn't it? This is not theoretical, it's happening now. And every time we cut MHPSS funding, we increase also the burden on all the services because, again, we are integrated. And distress doesn't disappear when you don't look at it. I tried, doesn't work. It shows up in malnutrition rates, in poor medical compliance, in social breakdown. Now let's talk about children. Save the children. If we don't intervene in a crisis that is shaping their present, well, it's going to shape their entire future. If they're exposed to traumatic situation without the support they need, they can experience long-term disruption in emotional, cognitive, social development. So if we fail to provide MHPSS for children facing constrained resources, we're not just failing them now, we are failing them for the decades to come. And I'm not just talking about emotional support, I'm talking about practical. I'm thinking about a child with severe mental health condition that need care, that include medication because he lives with epilepsy. Because without proper care, well, some of these children are not going to survive. At the heart of the humanitarian action, we have principle, humanity, dignity. If you strip away MHPSS, we undermine it. We are not just feeding people, we are helping them to rebuild their life. We are not just providing a shelter, we are ensuring they feel safe. We are not keeping them alive, we are helping them to live. MHPSS allows us to stabilize people. It allows us to regain control, protect ourselves, protect our family, and participate in our own recovery. So by doing so, you reduce external aid, you reduce all of this. So if it's not life-saving, well, I don't know what it is. So that's the end of my speech. From my heart, have I convinced you? I don't know. But remember that if saving life, and I've finished, means saving the whole person, mind, body, but in that sense, MHPSS, it's not an option, it's essential. Thank you very much.
And you did definitely convince us. And I think it's important what you do is actually it's unpacking MHPSS, that difficult concept, and really make it tangible what it means in the lives of people and how it can contribute to survival sometimes, but definitely to just a better quality of life and a better outcomes in many areas. And I always have to remind when I hear, let's say, an elevator pitch like this to what policymakers think. Some get it, some not so, but one who really got it was the former Minister of Development Aid in the Netherlands, Sigrid Kaag, who said, this is just a no-brainer. Of course we do this. And that's actually what I got from your talk as well. Well, the next speaker is myself. So now I need Brandon to be very brutal with me, or otherwise the panel will do it. I would like to talk a little bit about one specific setting, a setting that was close to my heart, or is close to my heart, the Sudanese refugees in Eastern Chad. I was in Chad several times. The last time I was there was last year when this horrible crisis in Sudan had happened and so many people fled to Eastern Chad. And this is a resource poor setting. The eastern part of Chad is really very poor in formal resources. Next slide. To give you some data, we talk about 770,000 new arrivals over the last 2 years, adding to already 400,000 Sudanese refugees who are there in not so pleasant circumstances, I can tell you, in a setting that was desperately poor and underdeveloped. That's what we talk about. And the needs around MHPSS are very high, as Anne said, if you look and if you listen. The national system in Chad for mental health care and social care is really weak. There is actually no psychiatrist from Chad in the country. There was one, he passed away and is not replaced. There is a psychiatrist now in the country and he's with International Rescue Committee. He's with an NGO in the East, but still only one. Also, there is no school for social workers. There is no school for psychiatric nursing. So it's really poor in formal resources, but there are of course also other resources in communities that we can work with. And then there is this refugee response plan for the whole region, and the Chad chapter was relatively well funded, 30% last year. That's bad. Next slide. So we have done a few needs assessments. Also, here are some lessons to learn. Some of the needs assessments were done with a toolkit, actually both of them, with a toolkit that Inka and team developed, the multi-sectoral needs assessment tool from the IASC. And the interesting thing here is that you see, particularly the one on the left, was done by 5 agencies, 3 NGOs, 2 UN agencies. That's a good way of using your resources and pulling together your resources. Next slide. Then Inka will be happy. We used the minimum service package. Now you may say, do you really want to introduce a minimum service package and have workshops in a setting that is so resource poor? We did it. And we're very happy we did it because it had really good outcomes. Really, the people in the workshops, those were from education, from child protection, from GBV, from livelihoods, from health, they really, after a workshop of 2-3 days, they got it. They knew what they had to do in each sector. And even more important, they knew what the others did. So there really increased collaboration. It is an investment, but it's an upfront investment. Next slide. Now, what does that then lead to if you have people? This is a brief surface mapping to say that resource poor doesn't mean resource absent. There are resources. So this is a mapping that we did in UNHCR in one of the provinces, Asunga. And yes, it's bad. It's really bad. But still, if you map all the NGOs and the local organizations together, you have 12 social workers, 18 psychologists, 5 psychiatric nurses, and 54 psychosocial assistants. That's not much, but you can do things with these people. Next slide. Now, what we do with this, and we means the whole humanitarian world, is first of all, integration of mental health in primary care. I'm a doctor myself. I know this is really essential for also the reasons that Anne mentioned. Some people just need acute medical care for their mental health conditions. We had almost 30,000 consultations for mental, neurological, and substance use conditions. Is that enough? No, definitely not. Is that nothing? No, it's not nothing. We do really meaningful work there. And we means, are the figures from International Rescue Committee. There are also other NGOs like MSF that are not included in this data. And yes, you need to train people. So we have tools, the MHGAP intervention, the MHGAP Humanitarian Intervention Guide, for example. Apart from that, 85,000 people received support through community health workers, MHPSS support, like psychological first aid. Next slide. But of course, MHPSS is not only a matter of health, it's also protection. And I want to give you just one example, an example that made me happy. A national NGO, APLFT, the Association pour les droits, pour la protection des droits. Anyway, I forgot the name. A national NGO, quite good, focusing mainly on GBV, but because of the work on MHPSS, they are really now including MHPSS when they talk with survivors and then when they talk with communities. These are not very difficult things to do, but it's a matter of building capacity. And the MHPSS people, the few that are there, can play a major role there. Next slide. My last slide also. The lessons that I've learned in low resource settings, make sure you pool resources. It really is in the interest of everyone in the end. Secondly, capacity building upfront is an investment, not a luxury. 3, integration. We don't always like it, but we have to integrate within existing sectors to get our goals realized. And lastly, we need to get out of our tiny bubble and work with governments, get governments in as much as we can, but also refugee-led organizations and community-led organizations. This really is something I see happening now, but we need to focus more on that. That's all. Thank you. So, thank you, Peter, for sticking to the time. We now go to Sofia Ribeiro, who is with the International Federation of the Red Cross.
Thank you so much, Peter.
Over to you.
And thank you so much for having us here. It's been very inspiring so far. I hope I keep the level. So first, I just wanted to frame a little bit the role of the IFRC, the International Federation for the Red Cross, Red Crescent National Societies. We are a membership organization, so we provide support to 191 national societies from across the globe. So with that in mind, and knowing that the topic today is about resource-constrained settings, when I got the invitation for this session, the first thing that came to my mind is the picture that I'm going to ask the colleagues to move to the next slide. And this was the first thing that came to my mind. So we conduct surveys systematically over every 2 years, and we've been conducting this ever since 2019. And one of the questions that is in this survey is, what's the biggest challenge for the implementation of MHPSS services? And systematically, the response, the one that tops, and I really put the table there so that you can see it is by far budget constraints in all of the regions. So when we talk about resource constraint, it's really not a new thing. It's just something that is a bit more daunting now due to the reality. but it is the reality for many of the colleagues that we work with. And I have to say, it's also the reality for the IFRC. We have been, for example, struggling with securing regional MHPSS technical colleagues. So some of the regions have been consistently having this, but some have been lacking. And so we need to get creative. No, we need to ensure that with the resources that we have, and particularly leveraging on a network of partner national societies, that we can, take advantage of the resources that are already in place. So one of the ways that we're doing this is that we are promoting and supporting the establishment of communities of practice or any other form of networks in the different regions. We do this in the language that is most used in the respective region. For the Africa region, for example, it's the only one that we have two, because we have a Francophone and an Anglophone community of practice. This is an opportunity for colleagues that would otherwise be a bit isolated, working on their own, maybe sometimes having doubts or needing to rely on someone that is simply not there, to rely on peers that, are sometimes neighbors, maybe sometimes a little bit further, but that are, colleagues that can understand their concerns, that can share materials. And by doing that, we're really, leaning on what Peter was just saying, leaning on the resources and leveraging that. This is also, I have to say, a source of inspiration, because let's face it, we need it. No, sometimes reality is a bit hard, and it's always good to come into a meeting where a colleague is going to tell you about something that went well, about the moment when their programs were recognized, about a breakthrough. And then, of course, it's also the good place to say, have you trained on this already? Do you have the materials? So it's really, a way to promote that peer support and to then again take advantage of the collective work of a network. However, we do feel that for the Africa region, that we know is by far the region with the least number of trained mental health professionals, we still feel that we needed a little bit of a further push, again, because as an IFRC, we have not been able to keep an MHPSS technical position in that region. So we felt we needed to go a little bit further. And so taking the example of the global roadmap that existed since 2021 to 2024, we proposed the region to follow the same model. So next slide, please. There's not a lot of content there. I just really wanted to show a little bit what was the collaboration. So we brought colleagues with the support of the Danish Red Cross and hosted by the South Africa Red Cross. We brought colleagues from more than 20 movement components, about 50 participants, and through a workshop of 3 days, we took them to a process that led to the draft of the Africa Red Cross Red Crescent roadmap. This was really an investment to, leverage the knowledge in the region, but mostly to have the colleagues from the region saying, this is what we want to prioritize. We know the needs are immense. We know that the resources are constrained, but this is what, from our knowledge, from the local knowledge, we want to prioritize. So after this workshop, we had a series of consultations that then led to, and that takes me to my last slide, led to the document that was launched late last year. And we are now in the process of, taking the best advantage of this. But one of the things that national societies are telling us is that they finally at least have a document, something concrete that they can show and say, this is what we consider a priority. And it's not just my priority, it's the priority for my colleagues as well. So my final message would really be that we need to lean on our colleagues and not on the networks around us, because that's a way that will really help to thrive in resource setting constraints. Thank you so much.
Thank you, Sophia. That was inspirational. It's always good to see what the Red Cross, Red Crescent movement is doing. Very deep community work. So thanks a lot for sharing. I would like to present now my compatriot from the Netherlands, Marieke Pijnenberg, who is a policy officer, now I should say it right, policy officer in humanitarian aid, but actually focusing quite a lot on MHPSS. You're working with the Ministry of Foreign Affairs and came over for this week here, The floor is yours.
Thank you so much. And I also really like Brandon in the back doing very discreet time management. So I like to continue doing that. So I would like to start with the fact that, and to emphasize that MHPSS is a cross-cutting team with relevance to a diversity of sectors and clusters. And this is really one of its strengths, but also really one of the difficulties of working with this team. Especially in times of budget cuts and reprioritization, there is really a considerable risk that attention and budget for MHPSS inclusive approaches drop. And this would be a mistake. And I might be preaching to the converted here, at least in this panel, and I'm happy Anne already made the case, because MHPSS contributes to the effects of investment. It increases the impact of our efforts, and leaving it out would undermine the results, but also the sustainability of the achievements made. Due to its cross-cutting nature and current budget cuts, effective coordination between agencies is crucial. It was also often lacking. This was until 2020. Next slide, please. Where basically to facilitate this integration of MHPSS in different sectors and also to foster coordination and collaboration between agencies and organizations working on MHPSS, the MHPSS search mechanism was established. This was based on the request of and a priority identified by the IASC MHPSS Reference Group. And what is this mechanism? It is a mechanism that supports humanitarian organization and interagency collaboration. So it's not deployment to one organization, but it's really deploying an expert to help the interagency coordination of humanitarian organizations working on MHPSS to avoid overlap. And this is extremely important, especially with the limited resources we are now talking about. So it is the rapid deployment of MHPSS experts to emergency and early recovery settings. We can do this rapidly due to prior vetting of the experts, and we build on a roster existing of over 400 MHPSS experts from humanitarian organizations, but also government, private sector, individual experts, and also existing of many cultural and linguistic backgrounds. Deployments are based on the standby partnership network, so organizations being part of the standby partnership network can easily request one of these MHPSS experts. Durations generally last between up to 3 months, with the possibility of an extension of 3 months more. And the current partnerships we can see here at the bottom of the screen. Next slide, please. So at the moment, the deployments focus on a variety of topics and can be requested based on the needs of the requesting organizations. This includes coordination, but also more specifically situation analysis, assessment, mapping, M&E, focus on capacity building, of more the technical support. We are really open to build on the request. So we're really open to find the expert necessary to meet the demands that are there. At the moment, the deployments are very much in humanitarian, refugee or early recovery settings, but in the future we also hope to expand this mechanism to facilitate more MHPSS efforts across the humanitarian development peace nexus. Next slide, please. And I saw, the implementing organization is the Netherlands Enterprise Agency. In Dutch, we call it RVO, and I saw they are online, so I'm hoping I'm living up to the task of presenting this mechanism. And how it works is you have requesting agencies, they fill a request, it arrives at RVO, and they really are the implementing organization and do the matchmaking. They facilitate a whole process around deployments, and also through collaboration with Antares, facilitate the psychosocial support of these experts themselves, because they are also deployed in very difficult situations and they have a high workload. There my colleague is. Hello, Omer. Then there is also very much the link to the IASC MHPSS Reference Group. So we have the co-chairs really facilitating the technical expertise and helping the deployees in country, so really providing this technical experience and advice. And then we have within the IASC MHPSS Reference Group, we have a steering committee. Also, a lot of people on this table are part of the steering committee, really making sure that the mechanism fits the needs. So we're able to adapt wherever possible. Next slide, please. Very quickly results. So from 2020, it should be, has been over 70 deployments, over 23 trainings have been provided. And as Terry already mentioned, the technical working groups in country have almost doubled. Results beyond the program also includes MHPSS experts being hired by hosting organizations. We often see organizations, through having an expert on board, really seeing the added value of having this MHPSS expertise integrated, resulting in them hiring the expert after deployment. And as in the case of Lebanon, also a government has hired one of our experts. It's sad for our program, but we're very happy this happens because it means a sustainable integration of MHPSS knowledge in the system. Next slide, please. This is the last. We are very open for organizations to join us. So if you are interested in hosting an expert or requesting an expert, please do reach out to us. That's it. Thank you so much.
No, great. And I can attest, I think many of us at the table have actually hosted experts, and this sometimes is really the boost for MHPSS. So the example that I gave from Chad actually started also with an interagency deployment from the Dutch Search Support, and that really kickstarts things. And I know the IOM has hosted several as well. So the floor is to IOM now, to my friend Guli Skinina, who is head of MHPSS and intercultural communication in the International Organization for Migration.
So I was wondering what to bring to the table today, and what could be the comparative advantage of my talk. And I think, probably the issue is that I come from an organization that deals with mental health and migration. So two words that are now on the list of the 200 words that cannot be even pronounced on websites. I come from a UN organization, but in fact, our funding mechanism is totally projectized. 70% of our budget comes from projects. So we function like an NGO, and 46% of this funding come from one single government, that is the US. So we had obviously a moment of despair. I had a moment of despair, for a few weeks, a couple of months ago, when all my projects in the field funded by the US were put on hold, as you probably know. And when the first program that was terminated was a psychosocial reparation program for indigenous community in Colombia, to the entire organization. So this, you can create which kind of climate this create, in the organization. But then, after the moment of despair, I went back to 20 years ago, when I started, 25 years ago, when I started to do this work, and you couldn't pronounce mental health, hoping to have funds. You couldn't mention psychosocial support without being laughed at, by, the serious humanitarian partners, and to the essence of the work. And since this experience was very much into me, when I trying to develop my field, in the organization in which I work, I tried always to have this in mind, where we came from and how we should operate. And so probably I thought that giving some examples on how we have done it, and how this actually won't be so negative for us as it could be, why and how we have done it. So we can go to the next slide. And the main issue is that for us, for my organization, MHPSS is an essential part of whatever we do now, after many years, An essential part called as MHPSS, but for me, they can call it as they want. They can call it specialized protection, they can call it health, they can call it direct assistance to migrants, they can call, whatever they want, as long as the menu of the things that we have to do is there. And that's what it is, because it's not in my own protocols, it is in their own protocols. It's in my emergency team, is in the transition and recovery team that work with peace building and transition and so on. Is it with the direct assistance to victims of trafficking, returnees, assisted voluntary return, that is a buzzword now, because obviously a lot of governments want to send people back. It's an essential component of that. Our reintegration strategy for returned migrants is based on 3 pillars. One of them is psychosocial support, so that's is part of migrant integration, is part of strengthening health system in general for everyone, and therefore also for migrants, because migration is a part of today's anthropology, and is part of migrants protection. So we can go to the next with some examples, no, that are more related with the humanitarian sector. I went back to 2011 when shelter and MHPSS were probably the two most distant, field of humanitarian response. What happened in Haiti? We were in Haiti, people were distressed, not as much by the death of the others, because they believed in voodoo, so somehow, this was a less, there was a lot of grief, but was a less important issue. They were distressed by the condition of the present, where camps were very badly set, overcrowded, not serviced, and so on. Then we told them, what we can do for you, what we can do in the given situation. They say, well, we are used to living another way. And that way was the laku, so living around courtyards where the enlarged family could live all together, and being tight. What was our main psychosocial intervention in Haiti was to suggest to our shelter colleagues, please put the camps in this form, not the others, around courtyards, not around corridor with house and house. Yes, we did, an evaluation, actually a long-term evaluation of the issues at stake, and people who lived in camps organized like that had many less psychosocial issues than the one living in the other camps. So it was, one way of doing psychosocial support. This brought then to all the integration that is now also in the minimum service package, but this was the beginning of it. We could go back to it, why not? Next one. MHPSS in health. Health is considered essential, also by the Dutch government in the new strategy, will be still one of the sectors that will be preserved. Can there be health without mental health? No. Do you have to call it mental health? No. No, you can call it something else. You can call specialized assistance. You can call it skills of the primary healthcare doctors. You can call them skill of the nurses, but that's what it is. That's what we are doing in Ethiopia, where our project is continuing exactly because it was framed in this way. We can go to the next. Livelihood support, development will be more important, so livelihood support and job inclusion. This is based on the buzzword about Ukraine now. We have worked on it, We have our manuals, our strategies on integration of MHPSS into livelihood support. This means almost non-costing, addition of elements of psychosocial support into the livelihood programs, so where you have, peer support, peer mentorship, counseling if it's needed, and so on and so forth, but done within that sector. So we are ready, Do we have to call it MHPSS? No, it's livelihood support, but my livelihood people will work with an MHPSS approach. So that's, a way to solve it. Final, the buzzword about migration will be security. No? When you see migrant in or migration in the new policy developments is avoidance of migrants and migration, in most of the governments. So we can go to the next slide. No, that's what I'm talking about. So we develop already a mental health and psychosocial support tool for migrants across points and points of entry. This means in assisted voluntary return and reintegration. This means at the point, of arrival. This means also training border police. They will be on the forefront, of these new developments. Unfortunately, they have their own issues. They are already presenting to us, moral injury being one of them, when they are forced to do certain things to migrants. Starting from there, you can bring MHPSS for migrants in, and that's how we are doing it. So these are just some suggestions from my side that I hope any, especially small organization, can find useful. Thank you.
Super inspiring, Guli, and the manuals are online, I think, and many of them. So this is really helpful to integrate, because this is the way forward, I think. Thank you so much. We go to Maria Bray from Terre des Hommes, Lausanne. You are, say it right, Global Advisor on Child Protection and MHPSS.
Thank you very much, Peter. Yeah, so I will be looking at, something that has been already mentioned, actually, but that one way of trying to go forward with MHPSS in resource constraint setting is to work with communities, right? And to prioritize community-led MHPSS and to support this approach. Maybe before I begin, and because I'm going to speak about West Bank and Gaza, I just need here to take the opportunity to condemn, and I mean, I guess that it's not only Fauteuil des Hommes, but together with the humanitarian community, the ongoing airstrike in Gaza, which is causing immense suffering and continue to claim hundreds of lives, including a devastatingly large population of children. So, so we know, and it has been actually already proven, and it was restated recently, that MHPSS is not an optional or a secondary intervention. It's a life-saving lifeline, particularly in crisis-affected and isolated areas. It plays a critical role in providing immediate relief while simultaneously serving as an effective means of outreach, and outreach linked with all, of course, essential services we mentioned. By leveraging existing local networks, MHPSS ensures an efficient use of resources while reaching the most vulnerable population, especially children and youth. In Gaza and the West Bank, where formal mental health services are often inaccessible due to insecurity, destruction, local community structures play an indispensable role in ensuring that support reaches those who need it most. So in Gaza City, we work with the local NGO, Beit Laia Development Association, which actually provide MHPSS for children through community-based spaces, allowing them to play, to connect, which help preventing trauma. These activities help also identify children with additional mental health needs and strengthen coordination amongst actors. Mothers, actually, you can go to the next slide. I just realized it's not there. Next. Yeah. Next, please. Yeah. Mothers in group session also discuss their children's distress, expressing concern about rising aggression and their own struggles, highlighting the interconnection again between MHPSS protection and humanitarian needs such as food and safety. So MHPSS is not only about individual mental health, but also about strengthening community resilience by fostering social cohesion, child protection, and coordination with other essential human services. Next, please. But for MHPSS to be sustainable, we really need to build on existing community mechanism. And this doesn't need much additional resources, right? It's about identifying the right actors, local actors, and building on existing mechanism. Example are, for example, extended families that plays a critical role in caring for unaccompanied and separated children. We are trying to strengthen this community-based protection mechanism by providing psychosocial support and advocating for cash assistance to help host families and ensure children's stability. It's also MHPSS professional inside and outside Palestine that actually support one another. In Gaza, local workers continue their life-saving work despite facing the same trauma. Their colleagues in the West Bank and Miyong provide remote psychological support and supervision. And this is a mechanism that we really want to build upon. So these examples illustrate again how community-led MHPSS fosters psychosocial mutual support and dignity in the face of adversity. And for MHPSS intervention to be effective, as we were saying, we really need to identify those local actors and try to empower them. And these can be young people, community members, religious leaders, teachers. I mean, the MHPSS Technical Working Group in West Bank is a good example of this model, where actually they've been putting in place local focal point in each governorate, where actually most of them coming from local organization, and that can lead coordination and response effort. And this ensures that these interventions are localized, relevant, and sustainable. In Gaza, many local NGO and youth organizations, have been playing an essential role in mental health and psychosocial well-being for the communities, and they need to continue being equipped to support and lead the MHPSS responses. The concept of, next please. The concept of Aslamud is also a key cultural concept to consider when you work in Gaza and West Bank, when supporting mental health and psychosocial support. It refers to this steadfastness that defines how communities live, resist, and rebuild amidst adversity. And this concept is really central to Palestinian resilience. So you have here the definition, and I do think that when you read that, you really understand that if you don't use those concepts and rely on those, you would really be missing something important when you support MHPSS. While local actors should lead, ongoing external support is also crucial, especially in volatile contexts. Challenges faced by local actors, insecurity, access restriction, heavy mental burden, and resource constraints, of course, significantly impact their ability to operate. And recognizing these challenges and addressing those are very important to continue those collaboration. We know that many MHPSS workers have endured the same trauma as those that they support. We've got a case manager who lost multiple family members and continues to provide care for children and family facing similar crises. The emotional toll underscores the needs for psychosocial support at all levels. So sustained international collaboration is crucial to support Palestinians' collective psychosocial relief and resilience, ensuring an effective contextually relevant response and long-term recovery. Next slide.
And that is also your last.
Yes, no, it is that. So I've just captured here again a few of the messages I've been sharing with you. I just want to re-emphasize that in contexts like Gaza and the West Bank, MHPSS is more than an intervention. It's a pathway to dignity, solidarity, and psychosocial relief and resilience, fostering life-saving support rooted in local realities. Thank you very much.
Powerful, but also hard. How can they find the courage to continue and continue? But yeah, MHPSS plays a role there to help people to do exactly that and finding their strength in adversity. Yeah, thanks, Maria, for sharing. We go to Ben Adams, and then we go to all of you. Finally, Ben, you are in the meantime, I think you are the director for mental health in CBM Global, and you will talk about leaving no one behind. And I guess it will be related to disability because that's your strong point of the organization.
Thank you, Peter. Slide, please. Okay, I appreciate I'm probably also preaching to the converted here, but just to highlight why inclusive MHPSS is an important topic. In humanitarian settings, persons with disabilities, especially those with psychosocial disabilities, face heightened and multiple risks, yet inclusion in MHPSS programming remains limited. With the global political, environment and economic situation placing huge strain on humanitarian systems, now more than ever, we must safeguard progress on diversity, equity, and inclusion. And we must strengthen our resolve to ensure that no one is left behind. Slide, please. So in 2024, after much work and consultation and engagement with a lot of colleagues who are in the room and online, the IASC launched the Information Note on Disability and Inclusion in MHPSS. And this was co-developed by a Disability Inclusion Working Group of the IASC, and the process included consultation and engagement with the disability sector, OPDs, and people with lived experience. The information note offers actionable guidance for inclusive MHPSS response, grounded in a human rights-based socio-ecological framework, the CRPD, and the voices of peer persons with disabilities. The information note aims to ensure that MHPSS programming in emergency settings is accessible and inclusive of people with disabilities, with all types of disabilities, and to support the deinstitutionalization of persons living in long-stay institutions and standalone hospitals. The note provides clear guidance and actions to support this. And I won't go any more into, I suppose, the content of the note, but it is readily available on the IASC website. So, building on this momentum, CBM Global, in partnership with WHO, has been leading the development of a disability-inclusive MHPSS package. And the package is being co-developed with persons with disabilities and the OPD movement. And in 2024, we piloted the inclusive MHPSS training in Nepal, the Philippines, and Ukraine. And each training was co-facilitated by MHPSS actors and people with lived experience. The training component takes a twin-track approach, so integrating disability inclusion across all MHPSS actions, and also addressing specific disability-related needs. It also facilitates collaboration and builds community between MHPSS and disability actors, centering lived experience and promoting sustainable inclusion beyond checklists and frameworks that we're also used to seeing. The co-facilitation model ensures accessibility and shared ownership. And going forward, I suppose the next phase for 2025 includes the development of a training of trainers toolkit, virtual and face-to-face training options, the rolling out of the TOT to priority groups. So we'll initially be prioritizing national technical working groups and those on the third roster, developing implementation and technical support mechanisms, inclusion metrics and monitoring tools, and strengthening OPD participation in MHPSS forums such as this. I suppose the goal here is really not one-off training, but transformation of systems and practices, and where actors feel supported to drive forward inclusive practices. So the package won't just contain training materials, but as I mentioned, we will also be looking at developing implementation and technical support mechanisms at a regional and global level. Slide, please. Moving forward, we need a real whole of sector commitment to embed disability inclusion, not as an add-on or an afterthought, which unfortunately historically has been the case, but as a foundational component in preparedness, response and recovery. Given the current landscape, and I don't want to keep going on about it, I think we're all living it, but especially as it applies to diversity, equality and inclusion, as leading voices and actors within the sector, we really need to embody what is inclusion, I think, and to really become DEI champions. At this juncture, I suppose there must be a concerted effort to ensure that those most at risk are not left behind, and that those hard-won gains, I suppose, that we have made in recent years are not lost. And despite the challenges we are all aware of, there is much hope and many opportunities for us to integrate this work. We have the tools and the expertise, many of you in the room and online, to take this work forward. Actors such as CBM and WHO and UNICEF and other IASC members are all ready and available to support. That's it from me. Thank you.
Ben, thank you for highlighting this. And this, I mean, we knew you would say it, but it must be said continuously. We should really work with people who have lived experience of disability, including psychosocial disability. So thanks for keeping us sharp. With this, we have ended the formal panel. So my slave driving capacity is done. Oh, you kept time. Thank you very much. So now the next task is to see if there are questions or remarks from the audience. We have a few people online already, but I would like to start in the room. For those people online, 140 at the moment. We also have 35 people in the room. Is there anyone who would make a remark, like to make a remark, or no? Then we go online. If so, please raise your hand, and you have to speak in the mic. So we will bring you a mic. I think maybe Brandon, can you find a mic for people? There is one here. Brandon, if you could do that, then there is an interesting remark, a difficult one, from Sami Youssef, who works in Iraq. Sami, are you able to unmute yourself and ask your question to the panel?
Yes, sir. Good evening.
Good evening. Can you present yourself and then ask the question?
My name is Sami Youssef. I'm working with IOM as a project assistant MHPSS. So we are here to talk about the suspension of funding by the USA government and how it is affect our mental health programs in all worldwide. Thanks.
Thanks, Sami. I think you know the answer to some extent from your own experience. So to what extent the funding stop, let's make it perhaps broader, the less available funding, how does it affect mental health programs? And I would like to ask people in the panel to say something. I see Guli is ready. I think you have gone through this, huh? You have, yeah. So Guli,
they are going in Iraq, in Iraq through this, obviously.
Is it? Wait, I think you need to push something, otherwise.
Can you hear you?
Yeah.
Okay, perfect. So they in Iraq are also quite much affected, because Iraq as a country was particularly funded, by US funds, for all the sectors of assistance. But I mean, the issue is the following: there will be different impacts on different organizations. As you probably know, the MHPSS sector of some NGOs has already closed working, so totally, from our colleagues. We were looking for them, they couldn't even respond to email, For us, as I said, probably as a UN organization, we are the first of the wave because we are projectized, but now all the rest, will come in a second. Sami, actually, I'm in touch with Binan and we are trying to find strategy, and the strategy, as I said, are those, so to go back to what we were a few years ago when MHPSS wasn't so popular, and we were able to, I don't want to say hide, but to be part of all the rest of the organization was doing that will keep, being funded by other donors because there is a need, and that's, and by the US as well, we hope, so, and that's the solution, Obviously, the first reaction was let's say that is life-saving, But the problem is not that, because for many of these governments, they might also understand that it's life-saving. For them is why they should have the burden of it, And so the rationale is really another, and it's a switch, in this sense, especially when you talk about migration, obviously,
Yeah, I can say a little bit about that as well. I think maybe there are others who want to say things also. But within my agency, we are having a bit of a twin track approach. To some extent, there are certain mental health interventions that are very easy to show that are life-saving, like, for example, managing withdrawal of substances, for example, or suicidal attempts, or people with acute psychotic breakthroughs. You have to help them, and people understand that. This should be part of standard medical care. And then, of course, there are other issues that you, I think it's not so different as what you say. You try to basically, if MHPSS becomes controversial again, then we don't call it MHPSS again, as long as we do it. The issue is, of course, that lots of protection work is also under threat. So it's sometimes difficult to find a place to hide, so to say. But I think linking it, I think education is another one where you can actually just have very basic MHPSS interventions. We call it socio-emotional learning. It's a no-brainer. People understand that if you have children who have gone through so many difficulties, that you need to train the teachers to deal with them. It's not difficult. And maybe, would you like to... No, well, you don't have to.
I mean, how much I'm supposed to wash our dirty clothes in public? That's the question. It affected us in the way of the way we are built and the decision we have to take. And that's why this life service came within the organization of colleagues telling me, you have to understand we have priorities. And my answer was like, the life of the people is our common priorities. And the fact we have for MHPSS, we have the same for gender, and we have the same for many other topics. It affects the human resources, obviously. Colleagues who have been trained and worked with us for many years that had to leave from one day to the others. Colleagues who has been investing also and working on other sectors and being our champion on MHPSS, being the one ensuring the quality or sharing some white flag when they saw that the situation was not as it should be. We are losing them also. So it's what you have built in terms of ally and champion within your own organization is lost in a way. We try to manage with all the funding, and we try to remember that, as I said, we are integrated. We don't want to be a sector. We don't want to shine in the middle of it. What we want is to continue the work. So in many different countries, we managed to do it by pure face and fight. In some other, it's going to take more time, and some country we're going to lose everything we have built. And that's.
Thanks for this, and thanks for we're not going to be in a negative mode after this meeting. We're going to end emboldened that we can do things, but yes, and it is actually a very tough time. It's the reality. We have a question also from Uganda, from Muse Mohammed Mohamud. Are you able to unmute and ask your question, Muse? If so, do that. It's a question to Maria, by the way.
Thank you so much. I think my voice is audible.
Yeah.
Yeah, thank you so much. I'm from Uganda, doing psychiatric about mental health at Kamal International University. So my question is, Dr. Maria Beria, how can collaborative community-led mental health psychosocial support model to be effectively implemented in low-resource cities? For example, you have already mentioned about Palestine and also Iraq. So for those, even in Africa also, we are low-resource setting while ensuring about sustainability and cultural relevancy. Thank you so much. That's my question.
Thank you very much for your question. I think it's a very interesting question, and I'm not sure I've got a kind of a ready-made answer. What I think, what is key in order to work towards a community-led MHPSS, I think is also the way and how to build this type of collaboration is also the way you're going to enter in discussion and in partnership with existing organization and existing local actors. I think it's a lot about managing to build equitable power relationship, and we are just now in Terre des Hommes starting to reflect on, and it's the right timing given the situation at global level, but just trying to reflect a bit more on what does it mean to question the power of international organization coming in, and how do you reflect positioning yourself on how do we come in, and we believe today this is the only way to actually build another type of partnership with local actors. What is true is that obviously when you think about existing local actors and building on existing mechanism, you believe that it can, and it does, can live in limited resources context, but still it needs investment and long-term, I would say, dedication, right? It's not happening, it's just not about identifying and say, yes, great, you do that, just continue and that's it. As I was saying, I think it's about finding this right balance about, collaborating with each other to make sure that there is also those resources, and sometimes there are indeed financial resources, that will enable those local actors to actually perform their work.
Thanks, and it reminds me also, and the question also reminds me of what I discussed recently with Moses Mugasa, Ugandan MHPSS professional with the Jesuit Refugee Service. And we also asked him about the funding, and he said, yes, we're very badly affected. But he says, but we are also having resources that are not cut. We are rooted in communities. We are working with them, and we will continue working them even on a shoestring basis. That's not to say all is fine, but I think it is a way that some organizations will not go away anywhere. They will continue. I also have a question online. I hope you can hear me. Ruma Gondaker from Save the Children. I think you're in Cox's Bazar, if I'm not wrong. It's a question to Inka. Can you unmute yourself if you can hear me? I don't hear. Maybe I pronounce your name not correct. Ruma Gondaker from Save the Children. If not, I will read the question. Inka, the question is, as an MHPSS professional, we understand the importance of the MSP and working across sectors. But the related advocacy to others and proper orientation to others is necessary for both donors and response authorities to make it accessible.
Okay.
Are you there? I'm reading your question. Can you do it yourself? You can do it much better.
Yeah.
sorry for, I was little bit away. So yes, actually I'm working in Cox's Bazar, you are right. So the thing is, as MSPSS, like P-level implementer, we are facing lots of challenges to do advocacy. Why this MSPSS intervention and approaches need to include into sectoral program. Whatever we can say is mainstreaming or cross-sectoral component, but from donor side, they are not really sometimes interested to inbuild into program. Even its health program, nutrition program, protection program, even education program. So all time we are struggling a lot. I know it's the same scenario everywhere in the world, but from actually the question from my side, if you have any advocacy with donor and policymaker, even the response authority, to include this minimum service package and other interventions, that would be really a grateful work for us, and it will be easy for us to, like convince and advocate people why it's important into our life. So that's all from my side. Thank you.
Yes, thank you so much for this very relevant question. I have a couple points. I want to quickly mention that there's MSP activity 3.1, which is orient humanitarian actors and community members on MHPSS and advocate for MHPSS considerations and actions. That also has some pointers on advocacy for sectors and has some relevant guidelines that are included there. Secondly, I would mention that we also do a lot of advocacy at the global level as well with different donors and organizations. So also feel free to contact us to the MSP help desk if you have any specific questions, because we're also in touch with various ARs and sector leads and so on. And sometimes we can work together to raise awareness on MHPSS. And third, I want to mention that there's actually a thematic group as part of the IASC Reference Group that is working on advocacy right now, that is co-chaired by UNICEF and Will Hoyt. Maybe you're already connected with her, but we would also be happy to connect you with this group because they're doing a lot of work at the moment that I think can be useful for many of us. Thank you.
Great. We have time for a few more questions. I'm looking at the room. The room is very silent, but there they come. You can take the mic. Yes. So, and introduce yourself and your organization and to whom the question is directed.
I am without an organization, looking for a job. My name is Alice. Nice to meet you, everyone. I wanted to know if you could quickly build on the positive experience in Chad, because you were actually talking about low funding. It's also a complex area. And just, I was thinking about Haiti, Afghanistan. How did it work well? Was it NGO-led? Was it government-led? Was it a lot of presence of the government? Why was it such a positive experience? Thank you.
I mean, no experience is 100% positive. It's more that you can do things also if your funding is limited. I think the main issues that I have learned in Chad, but I think it's also true in Afghanistan or in other settings, is you need to have some champions. And in Chad, that search support person was a champion. So someone who could really organize things and say, oh, but I am the expert. Don't worry, I'm not, well, no, that's not really the attitude actually, but someone who could say, when you have issues around MHPSS, I am the resource person. That's actually more how it should be. And that somehow also creates demand to talk in business language, so that people then say, this actually is important, can we get more? So I think it is important to have some people who could champion the cause of MHPSS. That's not super costly. That's just a few people who can do that and then can work with all the different sectors and organizations and help them with what they need. Governments, yes, you need to bring them on, but they often are not that very well sensitized, as Ruma also just mentioned in her question. So The other thing, of course, is advocacy. Is basically the question to Inka was, I think it is important to also have some senior decision makers understand that MHPSS is important. And my experience is everywhere you can find some people who say, actually, yes, this makes sense. And then things start moving. That's what I would say. Is there anyone else who wants to say something, Guli? Oh, sorry, there is a, oh yeah, this is good.
I can use this one. Maybe just to mention also that we have been in Chad, but also in other places, there is a bit of a regret, the fact that we have been there, for many years, with different levels of funding, but we haven't been, and there is still only one psychiatrist and he died, so that's the issue, So I think also the new situation will force us somehow, to work more on the nexus, that with the little resources we have, we cannot just respond in the easiest way for the emergency, but we have to build systems that are there to last, By instance, I think that at the end of the day, we would have done a better service to Chad if we spent a lot of the resources that we have received during the years in maybe promoting scholarships, of the doctors who wanted to be trained in psychiatry but didn't have where to go to France, where they could have, received their training and go back. Something that somehow, some mechanisms that are very rigid, that don't let, this passage between what is emergency funding to more structural element wouldn't allow. But with the new situation, I think they could, because I think the source of funding won't be as rigidly divided, in this issue, because they will be not traditional donors, probably anymore.
Thanks, Guli, and I cannot agree more. This linking, we have to change our way of working. Yeah. I think is this I think we don't have the time actually to do it because I have to wrap up now. How much do I have? 3 minutes. You can ask the question because we have 2 minutes.
Question, sorry. Good afternoon. My name is Mathilde Leloup. I'm a researcher and senior lecturer in Paris. My question can sound a bit strange now, but because we are in a resource constrained context, but I'm wondering if your various organization were considering the role of cultural practices in displacement context and the link between cultural practices or intangible heritage, for example, with mental health protection, because there is a lot to do in this field, and I'm leading a project on culture in humanitarian action. So I was wondering if you were considering it or not.
Yeah, the answer is yes, but in varying degrees, of course, I must say. But it's not a topic that is completely ignored. I don't know who wants to say, maybe our colleague from IFRC, because you work with communities actually as well.
Yes, I mean, we don't have much time, but to say the word localization has been there for a while, no? But probably it didn't have sufficient push as now. So for us, I mean, it's probably a bit easier because our national societies, they are national organizations and they work mostly through volunteers who are from the communities who are affected, no? So that is a little bit within the DNA of how we deliver our services. However, I would say we need to ensure that there's not a lot of experimentalism, if you will, that we still ensure that the services provided, they follow best practices, or if you are trying something out, this is sufficiently researched, because I think that's somewhere where, the gap is. We want to, ensure local practices, and maybe by doing so, we undermine a little bit also the testing of the effectiveness of what is happening, which by itself also deters the opportunity of replicating the same, no? So in short, that would be my answer. Thank you.
Thanks a lot. That was helpful. I would wish we had another hour. We have coffee afterwards or something else. But I have to close the formal session. I want to thank everyone for the participation. It was lively. It was a lively interaction this last half hour, and excellent presentations in the first hour. I cannot summarize it, but if I try it in my simplistic way, I would say what we really have to do is get out of our usual humanitarian bubble approach where we say we need X $100,000, we implement the project and we go again. We really need to work with both the communities much stronger and built with their resources, and this humanitarian development nexus thing. I mean, really working with governments and investing with them. That's one thing I heard from many of us. The other thing is also to really not just work in splendid isolation as MHPSS people. We need to get our good interventions used by whoever can use them. And with that, I'm ending this session. Thank you very much.